Good evening, ladies and gentlemen. Thank you so much for joining us today. We hope that you had a great week. We hope that you're having a fantastic evening, and we hope that your Wednesday and the rest of your week is a great one. My name is Corlette DeVoe, and I'm one of your co-hosts this evening. We have along with me my co-host, my dear friend, Dr. Crystal Rowe. Hi, Dr. Rowe. I will tell you that I'm going to embarrass Dr. Roll right now, just because. I I have such fond memories and experiences with Dr. Roll that I truly just want to say to her in front of everyone tonight that I think she is absolutely amazing. And as a Bahamian doctor, I will tell you that I've been around doctors for the last 30 years in the United States, in America, and all around the world. And I can tell you unequivocally that Dr. Roll is by far one of the smartest and most brightest doctors I've come across in my entire career in the medical field. So as a Bahamian, one Bahamian to another, Dr. Roll, I'm going to say this. You are making us super duper proud. I'm very proud of you as a Bahamian doctor. You know what you're doing. Great job.
Oh, thank you so much. You're so
Mhm.
kind. So very kind.
Thank you. Thank you. I think that you are absolutely amazing, and I just couldn't go by without actually telling you that. Okay.
Thank you.
Super. So this evening we are going to talk about safety, preventing wandering falls and other risks. So we're all here because we either have cognitive impairment or are caring for someone that has cognitive impairment. And the statistics show the importance of addressing safety when it comes to folks with dementia and Alzheimer's disease, because we don't think about it, but it happens. We want to be sure that folks with Alzheimer's disease are kept safe. It's almost as though you have to senior proof your home. Just as when we were younger, we had to baby proof our home for the 2 year old. Remember, we put those things in the outlet, then we had to move the pots and the pans and all the edges. Remember, we did that, y'all? We did. Now we have to get to the point where we are senior proofing our homes for our loved ones who have dementia. It is important because what you don't want to happen is for them to slip and fall or for something to happen because you didn't think about it. So, we want to talk about safety tonight and how you can keep your home safe to ensure that your loved one that has dementia or Alzheimer's disease is safe and does not have any issues with in the house or outside of the house or even with getting lost. Dr. Roll, is there anything else you want to share before we jump into it? You on mute, Dr. Roll? You're muted? You're muted,
Can you
Yoni.
hear me now?
Yes, we can.
Okay. Yes, it's important to understand that with dementia, um, wondering, superproofing, those things just come with stages. And it is important to understand that you're not only safeguarding your loved one, but you're safeguarding yourself in terms of risk and in terms of caring for that loved one. So safety measures at various levels are very, very important, especially for a patient with Alzheimer's dementia.
Thank you so much, Dr. Roll. Before we jump into the discussion, I'd like to share some information with you about dementia and staying safe. You may or may not know some of this information. It may be a refresher or it may be new for you, but it doesn't help or doesn't hurt to always have a reminder about certain things when it comes to caring for a loved one. So let me start off by saying that if you know someone with dementia, the statistics show that 60%, 6 out of 10 people with dementia, will get lost at least once. And What you don't want to happen is that one time that they get lost, that's the fatal time. And what we do know is that when seniors get with Alzheimer's or dementia get lost, 30% of them will be found fatally. I'm trying to think about the correct word besides just they're found dead in 24 hours. That's the harsh, harsh reality. You don't want that to happen to a loved one because you didn't think about safety. When it comes to, we typically think that folks that are in the moderate to severe stages of dementia may be more prone to wandering. But the data shows that wandering can happen even in the early stages of dementia, and it happens without warning. So don't think, oh, my mom is just a little bit forgetful. She's okay at home. You don't know when the wandering is going to happen. And don't assume that's only for the ones with moderate to severe dementia. It can happen to any person with dementia. So please, if you have a loved one with dementia, I'm going to ask you, start thinking about how you can safety proof that house that they live in so that if they do decide to get into that mode of wandering, they are safe and you're able to monitor them and keep them safe. Actually, my statistic here shows that if they're not found within 24 hours, up to 50% of those people who get lost risk serious injury or even death. And a lot of the death and the injury comes from falling, dehydration, getting hit by a car, traffic, exposure to the sun, or drowning. My neighbor is not on the call today, but I have a neighbor out west that lives a few doors down from me. 2 years ago, they could not, her mother wandered off. And this right there in Nassau, y'all. Her mother wandered off and they could not find her. And it took them a couple of days, and somebody said, let's drain the lake. And they found her mother in that lake. So what I'm saying is, be aware that safety is a big concern and a big issue when it comes to seniors with dementia. So please, we want to have a discussion about certain things that you can do in your house tonight, and what are you doing to keep people safe that you care about? What are you doing, and what are some of the things you can do? We're here to help. Another huge fall is number one in the world. Falling is a serious safety concern for all seniors. Every country in the world has the same issue. How can we keep our seniors safe from falling? Falling, and Dr. Roll, you can speak to this. Falling is the number one reason seniors go to the emergency room. Wow. Dr. Roll, you want to elaborate on that?
Yes, certainly. You're right. Falls are one of the most common causes of emergency room visits by the elderly patients. What we find though is that there are various reasons that patients fall, particularly within the environment. In terms of environmental hazards, may have been cases where there are rugs that are in places that are not attached to the floor or have the Velcro gripping. Um, Homes may not be equipped with guardrails or bars. There are cords that are crossing the floor. The bed rails may be too high. Um, there are steps in the home that the patient may not be able to see. Those are mostly environmental. Then you have physiological issues in terms of the patient may have risen from a seated position too quickly, altering the normal blood pressure, causing a bit of dizziness and imbalance. We have issues where persons who may need assistive devices not using the assistive devices properly. rendering their gait a bit more unsteady, causing the probability of falls to increase. We also have more physiological issues such as electrolyte imbalances or dehydration. As simple as having a sugar level that's too low or blood pressure level that's too high. Those things can lend to neurological issues that trigger falling. Dehydration, like you indicated, is one as well. So those things are things that you want to look out for um, within the person and within the home to prevent falling or safeguard against falling. So the same way new parents baby proof a home it's the same way you may want to look into baby proof, adult proofing, for lack of a term, your home as well. Another very common one is slip and falls within the bathroom. Um, you're trying to transition from the tub to the floor, or you're trying to hold on while you're taking a shower or bathing yourself. So in that case, we encourage the bath stool so that patient can sit while they're having a bath or sit while they're having a shower. A very common one within the Bahamas that we see, it may sound simple, but very common, cataracts. Cataracts present themselves in various staging. And sometimes, because the body has an adaptability process, sometimes we adapt to the cataracts, not realizing that our vision is obscured. So that within itself can be a fall risk as well, in addition to having a naturally unsteady or widened gait. So we find that all those things lend to increased risk for increased emergency room visits due to falls within our elderly population.
Okay, so now you see why I said she's amazing. Super smart. What do you have any thoughts here on what Dr. Roll just said? You know, about the safety. She gave some pearls here about things that you can do to keep your loved ones safe. Does anyone have anything they want to share about safety and how they are currently keeping the loved ones in their lives safe? Can you all hear me? Any thoughts on the comments from Dr. Roll?
So far, no, let's see.
Miss Kim, we can hear you.
Oh, so far, I have an aunt. In fact, I have two of them, but they are not quite there yet,
Mhm.
but someone is always there with them. And but I had a grandmother, but she had already died. But she um then she went to the hospital. They had to strap her because I guess she was at that point where she wanted to wander because when she started to talk, she usually talk about things we don't even know. Like she was way back when she was young and she remember the things like that. So she would say, well, I want to go down to so and so. So you don't know who's so and so. Yes, she lived right down the road there or something, like that. So they usually start, I think, like that. They would when they start, they want to wander and they don't want to stay put. So you really have to watch them. And then one time, I know this gentleman. I was in the store. He came in the store. He had Alzheimer's, but I think he came, back normal. And then he said, I need to call someone to come for me because he was in the store. He said, oh, I need to call someone to come for me so I could go back home like that. So I guess that was like maybe he was in and out.
And that happens. It depends on their their impairment, if they're mild, moderate, or severe. So if they're at the beginning stages, Miss Kim, then they will come in and out. And even so, when um, moderate dementia, Alzheimer's, it just depends on their level because they do come in and out. But they come when they have mild, they may be able to remember more things for a longer period of time. You know, as we're talking about safety, we think about wandering as one area of safety, but Dr. Roll also mentioned falls. And we want to keep aware that falls can happen whether you wander or not. So Dr. Roll talked about sometimes people go to take a shower and they slip in the shower. One thing I'd like to encourage you at this point, if you have a senior in your house, if you are a senior, whether you have dementia or not, the one thing that I would say to you is don't go, try not to take a bath standing up in your bathtub. That is a slip and a fall hazard for anyone over 65. It's a I'm not 65 and I slipped in my bathtub and I was like, I'm not going in the bathtub anymore. It is very scary. So we want you to think about safety for those with dementia and Alzheimer's, but actually I want you to think about safety as well for yourself if you're over 65. So as we are talking about safety, I'm sorry here, I've got people jumping in. Let's talk about safety in terms of medication. What does safety have to do with medication? Well, there's a couple of things. You may have that senior who has to take medication for their health. They have to take medication because they have high blood pressure. And now you're trying to convince this person with dementia why they should take their medication. Has anyone ever experienced anything like that? And Dr. Roll, can you share some insights to help our audience here understand how to get someone with dementia to take their medication, not just for the disease, but also for their other chronic diseases that they have? Any thoughts on that, Dr. Roll?
Yes, definitely. The first thing we always advise persons to do is sit down and have a medication review with your physician. If you are a primary caregiver for someone with dementia who may have other comorbidities that require treatment, you'd want to sit down and discuss that treatment modality the um with the primary care physician. In addition to that, you'd want to understand exactly how those medications should be given, the routes, the times the medication should be given. There are some medications that you have to give in the morning. There are some medications you can give in the evening. There are some medications that should not be given together, as well. And there are some medications that should not be given with food as well. And so all of these things are discussions that should be had, with your physician. Also at home, if you're the one responsible for giving the medication, then you would want to create a medication chart or medication diary where you keep a record yourself of what meds you gave when and how often each med you gave was given. There are also nice, cute little devices that are the pill tray or the pill container. Those ones are nice medication, nice trackers where you give the medication or you fill them. Either some of them are weekly, some of them are monthly, some of them are just for 7 days. And you can fill them, and some of them are detailed enough that they have morning and evening slots. You can fill those as well so that you can track exactly when your loved one is taking their medication as well. Also too, if you notice changes in your loved one's behavior when they are taking these medications. So that's also important to give an idea to your physician that, hey, when my loved one takes XYZ pill, they appear a bit more dizzy, or I notice shaking, or they vomit, or they complain about weakness. All of those things are important reminders that you can take note of. So when you sit with your primary care physician, um, you can discuss that. Another very important thing is polypharmacy occurs a lot in the elderly. And what happens, especially if we shop around in the Bahamas, sometimes we see this doctor, and then tomorrow we see a next doctor, and then the next day we see a next doctor. And they're all prescribing different things, or sometimes they are prescribing the same thing, and then this pill bag has the generic name, and then this pill bag has the actual pharmaceutical name. And so it's important, once you get an understanding of what all of those medications are, that you have them compiled. And another thing you want to ensure, especially with your Alzheimer's dementia patient, is you want to keep the medications out of the reach of that individual to prevent overdosing. Because sometimes if they don't remember themselves that they would have taken a medication, and they go back and take the medication and they're taking too much of it. So all of those things are very important pointers to help you safeguard in terms of medication safety. We can simplify the regimens. You speak with your doctor, hey doc, is there another pill that we could use that will give us the same coverage that she can take once as opposed to 3 times a day to ensure compliance? As simple as using the same pharmacy the same time, all the time, helps you to keep a track of all your medications, as well as you yourself keeping your log. So things like pill organizers, apps that help us to remember when you have to take certain medications, charts, things of that sort. Clear written instructions from your physician, or clear understanding from your physician also is very helpful in compliance and regulation of medication, and also observing the changes that you see. Because what it does is it minimizes polypharmacy, and it helps the physician to know when to stop a medication because, hey, this side effect is happening, or the next thing, or there's an interaction. And it's also sometimes we don't take into consideration, but there's sometimes on your medication package, they will tell you, don't take with grapefruit. Don't take with this product. Don't take with that product. Don't drink with cranberry juice. Don't eat it with don't take it with bananas. Those things are very important because those medications have interactions with those bases. So all of those things are factors that we could use to safeguard safety with medication protocol or giving medications.
Wow, that is phenomenal. Very, very thorough, very comprehensive, very knowledgeable, and very insightful. Okay, so let me summarize what Dr. Roll just said. Medication adherence is important for the safety of seniors and for the safety of folks with dementia. Don't take it for granted. Don't leave, she gave a lot of tips. Don't leave the medication around, especially for someone that has dementia. They may actually forget that they took the medication earlier. Wow, they may forget. That means they may take it again and again and again. You don't want them to overdose, just like you would not leave your medication around for your 2-year-old because your 2-year-old may just go and take it and think it's candy. Think about it like that with a senior that has dementia. Think this person is now 4 years old. I have to protect them. I have to think about them like they're a young child. It's do not feel bad. Just recognize that this is where they are at this point in their life. And remember, we were raised once a man, twice a child. So safety is critically important for us. So as we are caring for our loved ones, remember the most stressful part of caring for someone with dementia is worrying about their safety. That is the most stressful part. You've got to worry about if you leave them here, if they're going to burn their house down. You're going to leave them here, if they're going to fall. You leave them here, they're going to overdose of medication. There's so many things to worry about. So it's incredibly important to take some of these tips and try to integrate these tips every day so that you can keep seniors with dementia and your loved ones safe. Dr. Crystal also mentioned some of these medications cause dizziness. If they take the medication and they get dizzy, that is going to increase their chances of falling. Now you have another issue. What we also know is that when seniors fall and they break their hip, folks, their lifespan is decreased. When they fall and break their hip, the sad statistics, and I don't want to say this, but it's the truth. This is all statistics. When they fall and break their hip, their lifespan is reduced to 1 to 3 years. That means, in plain terms, they will not live longer than 1 to 3 years. Safety is incredibly important. We don't want them to fall. We don't want them to break their hip. We don't want them to overdose on medication. We won't want, there's so many things. That's why we're talking about safety today. Safety, safety, safety. I see we have another doctor on the line, Dr. Kirk Christie. Dr. Christie, welcome.
Yes, good evening all. It's a pleasure to be back on.
Thank you so much. And I know Dr. Christie personally, and Dr. Christie is one of those physicians who care tremendously about his patients and about people. And he brings a wealth of knowledge, just as Dr. Roll does. Dr. Christie, we're talking about safety first, how to prevent wandering, falls, and other risks among seniors with dementia. Dr. Christie, I want to ask you a question. How does dementia impact seniors psychologically and mentally to impact their behavior? I know you're a psychiatrist. Can you share with us how that impacts them, and does it cause their behavior to become a factor in their safety?
Yes, Paulette, it's a very good question. I think it was raised in the last month's symposium, and I discussed that there could also be co-occurring psychological and psychiatric conditions that may be co-occurring with the dementia. One of them could be depression. And so, as I stated last month, is that elders can present with atypical symptoms of depression. And so, in addition to the cognitive impairment where they're having short-term memory issues and also acute confusional events, there also could be depression where they could become withdrawn from their family. They could be oversleeping, or they may have a shortened sleep period. Usually, as you get older, the aged person loses sleep. And so it may not be unusual for an older person in the 6th or 7th decade of life to only have like 4 to 5 hours of sleep. But if you see an acute change where the sleep now is only 1 to 2 hours or 1 to 3 hours of sleep, then that may be a sign that the person may also be depressed. And so they may not voice that they're feeling depressed, or you may see some behavioral change, some distancing. They may not be engaging with the family as they usually do. And remember, there are certain symptoms that suggest that the dementia could be mild, moderate, severe, and profound. But persons with mild to moderate dementia, they can still participate in day-to-day activities where they're watching television. They may be watching a game show. They may also be engaged in social events with the rest of the family. But if you see that their pre-morbid functioning changing where they're not engaging with the family, you also have to consider that depression may be there. There may be also a period of anxiety, acute anxiety that may be occurring, where the persons may be having excessive worrying about the future. They may also have episodes of anxiety and be complaining that they feel their heart racing. There may be also other signs of an anxiety attack, which could be the sensation of butterflies. They may have flushing, and so they also may be worrying about their own life expectancy and also being worrying about the person's caring for them. So anxiety symptoms or episodes of anxiety may also be co-occurring with the elder person. Persons may also be worried about their finances, and this can fall under create stress for that individual, and they can also experience some stress disorders known as adjustment disorders, where they're worrying about the future. They don't know how they're going to cope with their finances dwindling. If persons didn't invest in their early days, they may be also worried about this as well. With more severe and profound dementia, there may be episodes of acute agitation, known as sundowning. And so you may have the elder who may experience these symptoms approaching dusk and coming into the evening period. They may become more agitated, also experience episode of confusion where they may lose time, or they're not have the concept of time. And so this also may appear during the middle of the day as well, and even in the early morning, and especially as the severity of dementia increases. So there's something called sundowning, or behavioral symptom disorder, where there may be acute agitation. There may also be uncontrollable anger as well, especially if they are confused, they're not aware of the date, what the date is, and also their surroundings. And they may also forget the carers, the principal carers. So as the dementia advances, then you may have these agitation episodes. I think that it requires caregivers to have some learning about dementia. There's a lot of online videos that you can watch. You can also read. And I think also the carers should have a plan of how they will manage certain events that may occur, such as if the person experiences anxiety, if there is acute agitation, that all of the carers have a little, maybe a weekly meeting or a monthly meeting where they can discuss these type of events that are happening in the life of their loved one. Also, carers can be susceptible to burnout, where they may also be experiencing burnout and stress, and they may project this on the elder that they're caring for. So it's very important for carers to be aware, self-aware of their own personal needs, and that they will need a break from time to time. And we often see that some cases of elders being abused by carers. And so caregiver burnout is really real. And so you need the core carers caring for that individual. They need a break. And so there must be some rotation, especially in cases of severe dementia, profound dementia, where the person has lost that short-term memory, the long-term memory, and they're totally dependent on carers for the day-to-day needs.
Fantastic. Thank you so much, Dr. Christie. A lot of great information. I want to ask the audience a question here. Does anyone have something that they can share with a loved one who has wandered in the past? You want to tell us about a wandering episode? What happened? How did you handle it? And what did you do to prevent it happening again? Anyone?
Hello, good evening, everyone. Good
Hi, Miss
evening,
Christine.
Scarlett.
Yes, how are you?
Hi, I'm okay, thank God. How are you?
I'm good.
Good, good. So, it's not much of wondering. My mom, she went through the phase of the sundowning. At the time, I did not know what it was. Once it reaches 3 o'clock in the afternoon, she would just be walking up and down, up and down. And she would sometimes go to the door and open it and saying that she's going home, because we're living in the States and we're from Jamaica, so she's always talking about going home. But she never went through the door because she's kind of scared to travel by herself, and I'm always watching her. But I didn't know it was sundowning until long, long after, when she passed through that phase. Then I learned about it. If I had known, then I would know how to deal with that better. So that's just what I wanted to say.
So around 3 o'clock, she would go to the door like she's going to leave to go home.
Yes, yes. And she would just be walking up and down in the house and saying that she want to go home. And we keep saying to her, this is home. And she's saying, no, this is not home. This is not Jamaica. And
Mhm.
I'm saying to her, I would ask her if she want like water or, something to eat. And she would say no. And I just didn't know what to do. I just keep watching her. That's what I usually do until when she calms down. It would like be for about like an hour, maybe an hour and a half. She would be
Mhm.
just up and down, up and down. And sometimes I said, Mama, you're not tired. She would say no, but that's just how it was. I didn't know what it
Mhm.
was. I didn't know how to, well, I know it was sundowning, but I didn't know how to deal with it.
Now, let me ask you, is your mom still alive now?
Yes, she is. She's 92, but she doesn't go up and down again. She is confined to her room from bed to chair, and that's basically how she is now. She
Okay.
she don't speak much. She can't have a conversation. If you ask her something, she might answer something totally different.
Mhm.
And sometimes she don't know us, but it is what it is. The doctor had told us that it's only gonna get worse. We do our best, my sister and I, and someone who helps me out to make her as comfortable as possible and play those classical gospel hymns that she loves. She don't even
Yes.
sing anymore. She have a beautiful voice, but she don't sing anymore. She will hum though, and that gives me joy when I hear her humming.
You know,
Yes,
Miss Christine, I am so proud of you. I'll tell you that
thank you,
you've been on the call in the past, and God bless you for caring for
thank
your
you.
mother and being patient with your mother and loving your mother and just finding joy in the simple things like hearing your mom hum.
Yes,
That's very touching for me. So,
yeah,
job, great job taking care of your mom. You know, I applaud you for recognizing that around 3 o'clock, your mom is going to
yeah.
start packing her stuff up because she's going home.
Mm-hmm,
It's incredibly important when you're caring for a loved one with dementia to understand their behavioral patterns and their quirks. That's one of the ways you can protect them. Because if you know that your mom around 3 o'clock is going to start getting ready to go home, you don't know when one day she is actually going to leave that house to go home. And that's
mm-hmm,
where the safety concern comes in. That's where the risk of something bad happen, comes into play. So you want to know how your loved one behaves and be able to preempt and prevent certain things. You knew that an hour and a half window, you have to distract your mom because in that hour and a half, she's going to be thinking about going home. So I'm going to encourage everyone on this call. I want to encourage you, get to know the folks that you're caring for, know their behavioral patterns and their habits. Know when something slight changes, no matter how small it is, recognize those changes. Those changes tell you a lot. And don't underestimate someone and say, oh, she will never walk. She will never leave. I will tell you that my father-in-law had Parkinson's disease and dementia, and he was confined to a chair, a wheelchair. And in the United States, unfortunately, his wife would go to work, and unfortunately, she would lock him in the house, double bolt the lock in the house. If the house ever caught fire, he would be dead for sure. She would lock him up every time she went to work. One day she came home from work and this man was not in the house. Where is he? Where would he be? He cannot walk. He's got Parkinson and dementia. He somehow escaped out of the house. Not only did he escape out of the house, I don't know if any of you have been to Fort Lauderdale, but he lived in Fort Lauderdale. 2 days later, he was found in Aventura, all the way in Miami. Let me share with you what happens with dementia folks. When seniors wander off and they get lost, don't think that they're going to walk wherever they want to go. That's not the way it works. Sometimes they walk. Sometimes they're going to walk to the bus stop. When the bus stops, they're going to walk inside the bus and they're going to sit there and they're going to ride that bus wherever they feel like going. And when they feel like getting off the bus, they'll get off the bus. Now, the bus driver may say, you know what, you didn't pay, but just go ahead. And that's how they end up 20 miles from home, 2 miles from home, whatever the case may be. So, as we're talking about safety, we want to ensure that all of the signs that you see that says, lost, have you seen me? We want to reduce those. We want to reduce the falls. We want to reduce the dehydration. We want to reduce the wandering and getting lost. We want to keep seniors safe. We're talking today about safety and how to keep seniors safe from wandering and falls, dehydration, medication, all of that.
Miss
Dr.
Corette,
Yes, ma'am, Ms.
Corette,
Lawrence? Yes, ma'am.
yes, I just want to say something else. I mentioned that when my mom usually walks up and down the sundowning period, I mentioned that I asked her if she wanted water, and she said no.
Mhm.
But it was long afterwards that a church sister of mine told me that at the time when they're confused, they just need some water to drink. Now, my mom, she is a person who I think she tells herself that she cannot drink a lot of water, and she literally don't drink water. When I asked her if she wanted water and she said no, I would just take it that she don't want water, and I wouldn't force her with the water. But long after, when the sundowning period passed, and I realized that she had constipation problems. So I put one and one together, and I figured out that it was because she wasn't drinking enough water. And I started to give her water, give her water. I forced her to drink it. I'll have to tell her stories like, if you don't drink the water, you'll end up in the hospital. And she hates to hear hospital. So I would tell her that. And I made up a little thing where I said, water is good for you, because she would tell me it's fresh. I said, Mama, water is colorless, tasteless, odorless, good for your body, inside and outside.
Mm-hmm.
And then she would drink it, because I noticed after the sundowning period and she was like in a calm, there was time when she would like get confused. And I said, okay, she needs some water. And after I give her that water, she would be okay. So persons who are here, if you're having issues like that, you could try giving them water. What I do nowadays, because it works for both things, the glucose, I put a little glucose in the water and give it to her, and she will drink it fine. And the glucose, they say it's good for energy. So yeah, so that's what I do. Every day I learn more, and I pray and ask God to give me the wisdom to deal with mama. And this program, it's very good. I share it with others. I hope persons are on who I share it with. And I thank God for you all, and God bless you for the good work you're doing. All
Thank you,
right.
Ms. Christine. I appreciate that. Let's
You're
talk about,
welcome.
I want to ask Dr. Roll this question about water. She mentioned encouraging a mother to drink water. We all know about the importance of drinking water to reduce dehydration. Dr. Roll, do you have any thoughts about her suggestion and how she was able to help her mom with drinking the water? Any thoughts on that, Dr. Roll?
I think once mom is not a diabetic, or if she is a diabetic, her numbers are controlled.
Glucose. Mhm.
Then definitely it's perfectly okay to flavor the water, because what we find is the older you are, the more distorted your taste buds become. So you find that regularly prepared food, the way you and I would prepare it, they'd find that it's bland or it's tasteless. And they prefer higher seasoned foods or more sweetened drinks. And that's because the older you are, um, the more deranged your taste buds become. So I understand why she refuses the water, because it legitimately has no taste. So in terms of hydration, we encourage persons to, you could do fruit infusions. Sometimes there are electrolyte infusions you could do, or we tell persons that you can brackish the water, for lack of a better term. I think we only use that word in the Bahamas, right? Brackish. And
Yeah, I don't know what
sometimes
that, what is that word? I have no idea what that word means
Yes,
when it comes to
blackish.
water.
We use that
What does
in
that
Jamaica.
mean?
Like put a little sugar. I don't know if that's what you're
right,
talking about.
right.
Yeah, but
That's the
So
but
same thing
don't
as
make it
putting in
sweet.
glucose. Isn't that putting in
right.
glucose?
So you can brackish the
Mhm,
water,
yes.
behaving terms with different things like coconut water,
Okay.
Gatorade, maybe
Mhm.
electrolytes, those things that encourage um getting fluids in. So that's perfectly fine once you're confident that if the person is diabetic, they're sufficiently controlled. We find that even
Mm.
just cutting up fruit slices and letting it sit in the water or infused in the water works very well as well. I've seen persons use the various flavored tea bags and just let the tea bag sit in the water, gives it a flavor as well. So all of those things help to encourage hydration
Mm.
um, within the elderly population.
Fantastic. And this is a part of safety. Okay. Thank you so much, Dr. Roll. I think Ms. Cooper has a question in here in the chat. Ms. Cooper's question is, do you have any comments, Dr. Roll and Dr. Christie, any comments about hallucinations? Do you have any comments about hallucinations, doctors?
Hallucinations in terms of what? Can you
Ms.
elaborate a
Cooper?
bit?
Ms. Cooper, can you elaborate a little bit about your question regarding hallucination, please?
Good evening.
evening.
Yes, my mom, she would look out the window, be looking out the window, and then all of a sudden she would say, "Oh, I see some dead bodies by the garbage." Or she would say, "Somebody is in the yard." And we have a um, ring doorbell. So of course we monitor her daily. She's not there alone during the day, but we still monitor her with the ring. And we would be like, we don't see anyone in the yard. You know, if anyone comes within a certain distance of your home, it rings to us so we would see them. And she would be like, well, they must be have something that they do that, that you can't see them on the ring, but I could see them. It's like she sees different scenarios every day, all day.
Hey, Miss Cooper, how long has this been happening?
I would say the end of last year into this year, straight through, and it happens, like I say, every day. She would call, and it happens too a lot when, as soon as the caregiver goes, I could tell you that in about 15, 20 minutes, she will call and have a story. And that would be they leave at 5 o'clock, like shortly after 5. And so as soon as the caregiver goes, she would call with a story. She's 89. She's a very active 89, very supple, no ailments. She was on high blood pressure meds, but we were able to take her off of those with other supplements and stuff. Um, and I was listening to the water as well, but she doesn't like water. She says it's tasteless. She likes Inshore and she likes Vitamalt and anything sweet. We've taken her off of sodas, but every now and then we give her one. She loves Coke. But like, and then like she forgets a little stuff here and there, but that's like we say with age. But the actual part that, like I said, the hallucinations with her seeing things, and when we tell her it's not there, like she get upset with us. She say every time she tells us something, we don't believe her and all of this, and so we just leave it alone. And I know sometimes when she goes to the geriatric um, um, doctors, they would say, sometimes to, go along with them sometimes, but I don't feel comfortable going along with it because when I did that before, she turned around and told someone, oh, even she saw it, and that's crazy. So yeah, when you go along with her, she turns it right on you and she'll be talking to somebody and say, there were 4 dead bodies in the road and even such and such saw it. They said they saw it. So I don't want to encouraging her because I don't think it's gonna spin a whole thing around. But then again, you can't tell her it's not there because then she gets all excited, upset, and says that, oh, nobody believes her. They think she's crazy, and this kind of stuff she goes along with.
Mm-hmm. Thank you so much for sharing, Ms. Cooper, Dr. Roll, Dr. Christie.
My question, has she ever been thoroughly worked up for dementia?
She has had a screening. She has had a screening. I think it was last year that I had taken her to the geriatric clinic. And they did a screening with her and everything. And man, she was able to answer those questions back and forth. She was able to do the exercises or whatever they had. She's very sharp. She was very, very sharp. She was a school teacher and also she worked with accounting. And so those taught still with her. And then, along with them talking with her, then they realized a little stuff that was slipping, with them talking to her. But like I say, it's not full bloom, but it's every now and then the little things that she does that we realize that, it's setting in.
Okay. In terms of blood work, has she had a thyroid workup? Has she had electrolyte workup? Have we looked at possible syphilis screening, all of those things? Was she worked up with those when she went to the geriatric clinic?
She did the blood work and everything. Can't remember, 100% exactly what they were, but it wasn't to the point where, she had to be admitted or put on a lot of medication or anything like that. The only medication that they gave us was something to stop the hallucinations, but it made her really drowsy and totally out of it one day. So we didn't give her it anymore. They wanted to give us something a little lighter, but we still didn't do it because that was really scary when we gave her that dose. And she was totally out of it, like slurring and everything, the majority of the day. So
Has she ever done a brain scan? CT brain?
no, we can't get it to do that.
Okay.
Mm-mm.
All right. So you said at
they
least
did want to do one of those though, but we didn't know. But she had some other tests. She had a scan, but it wasn't in it wasn't in the cocoon. I forget what it named, but you know what I mean. It wasn't the whole body push in. She would
Is
not
that
do
the
that.
closed MRI? Oh, no, the closed
Yeah,
MRI,
she
right?
would.
Okay.
Yes, she would not do that. But they did something that scanned over the body. Can't remember exactly what the name of it was because it was like the end part of last year.
okay.
It was something to scan the brain though, or to see how active it was. And they did say that the brain is shrinking a little. It is shrinking. But as far as to say, like I say, put her on medications or do anything drastic, that hasn't been said or anything like that.
Okay. We find that there are so many types of dementia, honestly, and dementia has various ranges, mild, moderate, and severe. We also find that based on the type of dementia, there are hallucinations attached, whether it's visual hallucinations, whether they're hearing things, whether it's tactile, sometimes they feel things, and it happens through various times of the day. Now, once all the baseline causes would have been ruled out, and you're confident that this is happening multiple times a day, then physicians most time would go to behavioral modification medications. I'm not sure what they would have start you on, but sometimes it's a trial and error because you find that today a medication works and then tomorrow it's not as effective as it should have been or as we anticipated. Most of those medications, they do come with hefty side effects like drowsiness, or some persons have explained to me that their mother or father appears too flat. They have no emotions. They don't do anything anymore. They can't do any baseline functions that they used to do before. So they decide to stop the medication on their own. So and then you're saying that she's not on many medications. So she's somebody that I think since this has been happening from last year to this year, should have a thorough workup again and to see if there's anything new underlying that may have been there that's now exacerbated. And if there isn't, then do a proper, again, a dementia screening to see if she has one of those types of dementia that has hallucinations attached. And then the next step would be to do the trial of medications to see if you can modify the behavior, modify the hallucinations. Now, in terms of agreeing and not agreeing, that's kind of a toss-up. Because sometimes you find that when you do agree, the same thing happens. They say, well, she saw it too, so I'm obviously not crazy. And then just like you said, sometimes when you try to say, well, mommy, this doesn't exist, then they become agitated and then you're seen as the enemy. Sometimes it's just best to let them say what they want to say and just not comment on it at all.
Yeah, that's what we
But
try to do.
as it's
Not comment sometimes.
Mhm.
Not comment. But I know I don't want to interrupt, but one of the medication that they did give her,
front
when
of
we
me.
looked it up to say what
Mhm.
it does, it was something that was administered to persons with schizophrenia. So that was another
So
reason why we
So you'll find that a lot of our mood stabilizers, and Dr. Christie can answer that, they are crossover antipsychotic drugs. Just being honest with you. So even though it's broadly labeled as a medication as maybe used in schizophrenia or bipolar, you find that it has other effects that we can use in dementia like behavior. That's why they would come under the broad umbrella of a mood stabilizer, that type of thing. So you would find that once they're under that family of antipsychotics, where regardless of what we're using it for, whether it's behavioral control, cognitive and control, that type of thing, you would see it used for psychiatric illnesses as well. So they kind of lap over a bit. But it's not to scare you, or it's not to say that mom has schizophrenia, but the drugs do overlap in what they're capable of doing in terms of what the physician is trying to achieve. But I would honestly advise that you, considering this is a concern that has not been thoroughly addressed, I think, she can do a workup again just to make sure underlying everything is clear. And then perhaps if you are concerned about that type of medication that she was on being dizzy or having a zombie-like, then you can opt to have your physician try something else. I have a question for you. Which geriatric clinic does she attend?
the one in what is it, Anstown Clinic?
Okay. When is she scheduled to be
Anstown.
seen again?
Well, we haven't taken her for a while. Today actually, my sister is taking her to a clinic just to be screened because we want to the caregiver has a week off, and so we want to take her to one of the the homes to just have someone who she people who she can interact with. So we're gonna do that for a week with her and see if that helps with her being around other people and stuff like that during the day, like a daycare.
Okay. Okay.
Yeah.
Now,
So I don't know
I
what
just
type of training they would do, but
mhm.
I don't know. I guess just something basic because the place does require a doctor note to say that she is fit to be, in the daycare at the daycare.
Now I do want you to be on guard to know that that week maybe not be enough time to settle her or to see exactly how she does because that's a new environment.
Mhm.
So it may take some more time for her to adjust to the new environment. So you may actually see some different behavior because she has to acclimatize to a new environment. So just keep in mind that the week experience may not be enough for her to adjust.
Very,
Yeah,
very good point.
we kind of know that, but just just some place for her to be and not to be home by herself.
Understood totally.
Mhm.
And
So,
that's a
Ms.
good thing to
Cooper,
do.
why not take her there for more than a week? Why not take her there, make that a
Well,
permanent thing?
we once she goes someplace, they need to do this, they need to do that, they need to do the next, and it's boring. So we see how she goes.
Okay. Well, as Dr. Rolls said, it may take a little bit longer than a week, and maybe just keep taking her there so that she can have something to do that will help her with her socialization, her cognition. It actually helps. And you might be surprised. She'll make some new friends and she may be different. So instead of taking her 5 days, maybe just take her 2, 3 days a week and see how that goes, right? So there's just so many different options, but I think that's a great idea to take her. Dr. Christie, I know
Yes,
this is right
good
up your
evening.
alley to talk about hallucinations here. Can you share your
Yes,
thoughts on this conversation?
yes. So Dr. Roll is quite right. We have to look at the duration of symptoms, especially with the acute onset of these thought content abnormalities and perceptual abnormalities, such as hearing voices or seeing strange things. So certainly with the acute onset, you have to rule out a medical cause within days, hours, or days with the onset of symptoms, especially in a normal individual. And so I just want to iterate that it's very important for elders to keep their regular medical checkups. And if for whatever reason that you're unable to get to the gerontologist or geriatric specialist, to reschedule right away. Because sometimes, things happen. The carer, sometimes you're stuck in traffic or something happens with your loved one that the carer is unable to get there, or the family members unable to make the clinic date or appointment. But it's very important to reschedule. Just call the clinic personnel, call the medical records so that they can reschedule you in. But endeavor to keep the appointments, because sometimes, life happens, work happens. And certainly for all adults here, I would say keep your medical appointments in the normal scheme of things. Sometimes we get caught up at work and we don't prioritize medical health and physical health. So keep your appointments. But if there are any issues, you always reschedule. So hallucinations and paranoia, not unusual with Alzheimer's disease, and also Lewy body dementia. So these type of dementias, you will have signs of hallucinations, which are perceptual abnormalities, and also even paranoia, where the person may have these false fixed beliefs that are out of keeping with acceptable societal norms. They may have delusions of persecution, where they feel people are trying to get them or take their life. And so the paranoia may also be evident in addition to the hearing voices or seeing strange things. So I think what's very important to note is that the doctors, we don't rush to administer any type of medication, whether it be a mood stabilizer or an antipsychotic medication. And my colleague, Dr. Roll, is quite right. We select appropriate medications for patients based on the case, and there are guidelines for the administration of medications in the elder population. And we look at the smallest dose possible to achieve the desired effect in the individual. And it will take some time. And physicians will tell you, as a rule of thumb, we always start low, go slow. And even more in geriatric medicine, start low, go slow. There was echoing.
Thank you
Yeah,
so
we
much.
did have an echo.
Okay. Yeah.
Yes, fantastic. Thank you, Dr. Christie. Great
So,
insights
and keep the
as usual.
follow-ups. Keep the follow-ups, and don't be afraid if medicine has to be administered. It will be administered in the very lowest possible dose, and the doctor will see the patient back on a regular basis.
Yes, thank you so much, Dr. Christie. So tonight we were talking about safety first in those seniors with dementia and Alzheimer's disease. And we want to be sure that safety is at the forefront of everything that we do as caregivers. So please, if you haven't done so, consider senior proofing your house. Your loved one may not have moderate or severe dementia. That's okay. Senior proof your house. Think about rugs in your house. Think about the shoes that they wear in the house. Think about the lights being on at night if they have to get up to go to the bathroom. Think about what you can do to make this house safe for a senior with or without dementia, because their safety is paramount. And remember, the most stressful part about being a caregiver is worrying about your loved one's safety. So let's make that a priority and try to keep our seniors with dementia safe. There are some wearables out there and some things out there that you can do to keep your senior loved ones safe. If they have dementia, I will also recommend changing the lock on the door. Make the lock on, you don't have to lock them in the house like my mother-in-law did, but you can certainly change the lock on the door. You can put in those locks. There's certain locks that you put in that makes it difficult to turn the knob, just like you would buy for your 2-year-old, makes it difficult for them to open the door. Think about buying locks to prevent your loved one from opening the door and walking out and getting lost. Think about maybe putting a wearable on them that will monitor their location to reduce the risk of them getting lost. Think about having certain alerts so that you'll know if something is going off, something is going wrong. Think about having something that will monitor their blood pressure, monitor their vitals, because as Dr. Roll said, sometimes people take too many of the same pill because they forgot an hour ago that they had taken the pill. They may end up taking it again, and that causes problems. So I know Dr. Roll is working with us on a research project with the Bahamas government. The Bahamas government is rolling out and testing a pilot in the month of August for seniors with and without dementia to help with wandering, falls, dehydration. If you're interested in participating in that, reach out to Dr. Roll. She is at PHA. Dr. Crystal Roll, if you're interested in enrolling your loved one into this pilot, reach out to Dr. Roll, because this is all about keeping the seniors with dementia safe, reducing the risk of falls, reducing the risk of dehydration, medication non-compliance, and so much more. We want to keep them safe. We want to keep them around as long as possible. And if we all work together, come together, we'll ensure that our loved ones stay safe, but also live longer so we can enjoy them as long as possible. I want to give Dr. Christie and Dr. Roll the last word before we wrap up for the night. But before I get to the doctors, let me ask if there's anyone else here that has anything that's on their mind that they want to share with us tonight. Okay, so remember, we are here the first Tuesday of every month. We try to have a different topic, and we also try to allow you to speak and share whatever is on your mind, because we want to be here as a resource. We want to be here as a lending ear to hear what you're going through and also to support you. Dr. Roll, do you have any last comments before we wrap up? And then, of course, Dr. Christie, your final comments?
I just want to say, you know, as we together care for individuals with dementia, safety must always be our guiding principle. To do that, we have to ensure safe environment. It doesn't mean that you would automatically all the time be able to prevent wandering or prevent a fall. But if you have these measures in place, you know, you create a safe space, you create a routine, you create trust, you develop emotional security. Those things help collectively to render support to the loved one. As caregivers, it's important to maintain a consistent, calm routine for your loved one. It's important to understand that if you minimize clutter, have adequate sunlight in the home, use advanced technology like alarms, monitoring devices, trackers, those things that help simplify the complexity or the possibility of patients, the things that you have to do for your patients. It's important to be alert, to kind of preempt in an effort to prevent anything from happening. And importantly, as well as the caregiver support group, it's important to take care of yourselves so that you can be better equipped to take care of your loved ones. And let's remember that behind every behavior, there is a need, even though that person cannot possibly articulate that needs you, but behind every behavior, there is a need. And behind every need is a person that deserves the dignity, they're deserving safety, and they're deserving love. And all of those factors help to enhance quality of care for our aging ones as we take care of them. That's all I have to say.
Thank you so much, Dr. Roll. Dr. Christie, any final comments?
Yes, thank you, Mr. DeVoe, for inviting me again. A pleasure to be back on with you. I just want to say that if anyone requires more information for psychological or psychiatric intervention for their loved one, you could email me at info@kirkchristie.com. I just want to say that the safety plan for your loved one should be discussed with the carers or the family caregivers. You should strive to have like a bi-monthly meeting just to discuss any issues that are going on, any behavioral and psychological symptoms that you're seeing. I just want to iterate in light of the summer, pool safety, certainly for persons with moderate to severe dementia, to have your pools secured, also screen doors or any egress to a pool area to have it locked, especially if you have an elder who's suffering with the dementia disorder. And also be careful in bathtubs, if not to leave your loved one who is diagnosed with dementia alone in the bathtub. So you could use certain surveillance, as Dr. Roll had mentioned, cameras that can be placed in certain areas of your home, on the exterior and the interior of the home, to monitor. And just want to wish everyone well and enjoy the rest of the summer. Thank you.
Thank you so much, Dr. Christie. And thank you so much, Dr. Roll, for your, as usual, both of you bring your insights and your expertise to the conversation. Thank you so much all for joining us. Remember, we'll be here again next month. The first Tuesday of the month will be August. What is the first Tuesday of the month, y'all? That is August 5th is the first Tuesday of the month. So we will be here. It's the same link every month. And please, we encourage you to join us. We want to be here as a support for you. And we will always have our doctors on the call to provide insights and guidance as needed. So thank you all, and I wish you all the best evening ever. Bye-bye.
Goodbye. Have a good evening, everyone. God bless
Good
you
evening.
all.
Good evening, everyone. Take care.
Bye-bye.